Sorry. We're now on item 8, which is the stroke services, which is page 59 to 60 in the report. Can I just say, members, before we start, obviously this is a very emotive subject and it's going to bring a lot, but I'm going to be very strict about timing to allow everyone to be able to speak. I don't want people not to be able to speak, but we have to keep this focused. So I am mean, so, just know that I'm quite mean, okay? So then we know where we're going from. Okay, so I'd like to introduce our officers first, please, on the stroke service. Would you like to introduce yourselves, please?
Good morning, everybody. So I'm Dr. Bernie Marden. I'm the Chief Medical Officer at NHS Somerset Integrated Care Board.
Good morning, everybody. I'm Julie Jones. I'm the Programme Manager for Stroke, Neurorehabilitation and Community Hospitals.
I'd like to say that we're also joined online by Dr. Meredith Kane. I want to say hello.
Hello there. Yeah, hi, I'm Mary Kane. I'm the Medical Director for Musgrove Park and Yeovil District Hospital.
Oh, well, welcome very much. Thank you. Thank you to officers. Thank you very much for your time today. We do appreciate it. We first have our first speaker, which is, I was able to pronounce the name earlier, Eva Bright. Lovely, beautiful name. Over to you.
Oh, thank you. I won't breathe. Okay. Right. In Yeovil, given the Thorn Lane housing development, Wyndham Hill, with Primrose pending and smaller unknown developments, this means a significant increase in the local population. Surely this proposal by the ICB and the Trust...
excuse me, that's not the right question that you were going to...
No, but right, okay, I can speak on what I like, I think. You've got the questions, okay, you've read the questions, presumably you've got the answers. This is important, okay, because the increase in housing, okay, in the Yeovil area, we're not...
I'm sorry, Eva, just one moment, please, one moment, please. You asked a question that needed to be answered today. We have an answer to your question.
Good.
So we need you to keep focused on the question that you originally asked, please.
Okay. So we're talking about drive time, okay. The fact that it will be not just Yeovil, the whole of Somerset, parts of Wiltshire and Dorset, all them. I wonder if the consultation will say they're biased in parts of Somerset, Dorset and Yeovil and the whole of Somerset, like they did with the St Andrews proposed closure, but okay. Okay, regarding the increase in drive time, there's a problem with recruitment and retention of paramedics. Okay, they get burnt out. So we have emergency care assistants on £11.11 an hour, but on tarmac ward, okay, so saving lives, they're not fully trained.
Eva, can I just...
This is relevant to the drive time, Chair.
One moment, please.
Sorry, I'm sorry.
It's all right. Don't worry. We understand exactly how you feel. It's just that you've asked a specific question for 3 minutes.
Relevant.
But no. You've asked a specific question that has been sent in. So what the officer is saying is, would you like the officer to read the question that you...
No, I'll do it.
Thank you very much. Thank you.
Okay, so there will be a significant increase in drive time. There's no doubt about it, okay, in rural areas especially. So I think it was Dr. Whiting or Mr. Whiting, the consultant, saying that it's time sensitive regarding strokes. And, I know that paramedics can do clot busting drugs and things like that. I'm not medical. Well, I've been told that. Okay, I'm wrong. But the key thing is about getting there with scans, all right? I was saying about first responders.
You've had 2 minutes.
Oh, thank you. God, it goes quick. So I know you can't reverse privatisation. But whatever you can do to mitigate it.
I'm sorry, Chair, I am going to have to step in. That still is not the question that was submitted.
Okay then. Okay, I'm sorry. Can the Health and Wellbeing boards
not the Health and Wellbeing board
guarantee? Yes, the question. That there won't be a worse service.
You've only got half a minute left.
Yeah, thank you. There won't be a worse service regarding people who've had strokes, people from, I've said the whole of Somerset, Yeovil.
Thank you ever so much. That's the 3 minutes.
Yeah, apologies for that. I thought I could say.
No,
other
no, no,
things.
you have to keep to the script, I'm
Yeah,
afraid.
yeah, because in
So,
the,
so
yeah.
I'm going to hand over now to our officer. So
Yeah.
that's fine. If you turn your microphone off, we will answer. There's your question and it will be answered. Thank you. No, but this is not the Health and Wellbeing Board. This is the scrutiny. So we're scrutinising what you're saying. So it's slightly different, but don't worry. Thank you so much. That's all right. Love. We're all learning the rules. Don't worry. Don't worry. Carry on then, Jean.
Thank you, Chair. So the question that was submitted was regarding the proposed closure of Yeovil Hospital acute stroke ward. It has been suggested by portfolio holder, as was Councillor Shearer, if I am correct, that as long as a patient reaches hospital within 4 hours, they will receive the necessary care and requisite treatment. However, according to the Trust's Dr. Whiting, with a stroke, what matters is the total time taken from calling 999 to having a scan and starting the right treatment. Given that the NHS is on its knees and unravelling due to the privatisation voted on by the coalition government, and indeed prior to 2010, patients who live in Yeovil, the whole of Somerset, parts of Wiltshire and Dorset, will most probably have a much larger increase in drive time than 4 hours. Ambulances will be waiting in long queues outside hospitals such as Musgrove Park Hospital, referred to as Tarmac Ward by paramedics in unison. Can the Health and Wellbeing Committee guarantee that stroke patients from the above areas will not be adversely affected regarding how a patient will recover? The response I'm about to read has been prepared by Maria Hurd, who is the Deputy Director of Innovation and Transformation from the Somerset Integrated Care Board. We all want every stroke patient in Somerset to have the best and most appropriate care possible. After a stroke, if the right specialist treatment, care and support is received, people can go on to live full and independent lives. We know that our acute hospital-based stroke services are not currently set up in the best way, and that there are differences in the way these services are delivered due to staffing pressures. It is important that Somerset NHS commission high-quality stroke services which are sustainable and fit for the future, which is why we are proposing to change the way acute hospital stroke services are organised in our area, so that everyone in the county will have the best opportunity to survive and thrive after a stroke. The public consultation sought to understand views on whether hyperacute and acute stroke services should be provided at one hyperacute stroke unit in Somerset, and if that is the right way forward, whether the unit be based at Musgrove Park Hospital in Taunton, and acute stroke services at either two acute stroke units, one at Musgrove Park and one at Yeovil District Hospital, or one acute stroke unit which would need to be located at the same hospital as the hyperacute stroke unit proposed to be Musgrove Park Hospital. For patients who have experienced a stroke, the formal clinical target is related to thrombolysis, which should be given within 4.5 hours following a stroke. This is what Dr. Rob Whiting was referring to when talking about what matters is the total time taken from calling 999 to having a scan and starting the right treatment. The majority of patients who have a suspected stroke are attended by an ambulance, who communicate closely with the stroke team, who communicate closely with the ambulance crew throughout the journey to hospital, using the time to order investigations, review past medical history, and undertake any other necessary actions to save time when the patient arrives at hospital. Patients are taken directly into the hospital under the stroke team and do not wait in the back of an ambulance to be assessed. A longer ambulance journey that results in the patient being met by specialist stroke staff can mean that treatment can begin quicker. We know that treatments given by a more junior doctor than a stroke consultant take longer to be administered. Getting patients to the right place to be seen by the right specialist staff is of the utmost importance. If we can improve the time stroke patients receive their initial treatment, we would mitigate the increase in journey time for those people whose journey times would increase.
Thank you very much. Thank you. And thank you for coming today with that question. Thank you, Ava. Very kind. No, it's absolutely fine. But thank you very much for today. Thank you. I'd now would like to invite Julie Jones to do the presentation, please. Thank you.
Thank you, Chair. I'll just begin if I may, and then hand over to.
Could I ask that you move your microphone a bit nearer to yourselves, because it's not picking up your voices brilliantly. Thank you.
Is that better? Yeah. So the treatment of stroke is one of the most impressive success stories in medicine that I've witnessed over the course of my career. When I was a junior doctor working with stroke patients, we weren't able to do very much at all. So I was dealing with patients and their families, and we were just waiting and seeing what would happen. Would the individual wake up? Would they be able to swallow? Would they be able to take on board nutrition? And it was a desperately difficult situation. Those who are going through stroke and their families and carers still face a really difficult and desperate situation, but there's so much more that we can do. But like every advancement in medicine, it comes with additional challenges. Interventions bring complexity, and to be able to administer the kinds of treatments, to do the right kind of diagnostic tests, and to access the right form of expertise to keep people safe and to give them the best possible chance of a successful outcome, it requires us to pay attention to so much more than we had to in the past. Now, we know that things are going to get more complex still. We have an ever aging population, increase in frailty, and that will bring complexity too. Patients will have more what we call comorbidities, which will lead to more complex care and medications. And the critical time around when we're administering treatment for stroke will require ever more intensive attention and a different organisation of services to sustain it. And we need to be doing this over a 24-hour, 7-day period. So this consultation around what is the best thing for us to do in Somerset is rooted in that sort of backdrop. We want to maintain, as we do now, the highest quality care, and we want to be able to have that delivered by skilled professionals in a reliable way into the future. And what we're trying to do is to answer the question together of what is the best way for us to do that, such that it is sustained, reliable, and as safe as it will need to be going forwards. So, Julie.
Thank you, Bernie. Can I have the first slide, please? So the bubbles that you can see here are the stages of stroke care. What we're looking at here, is the red hyperacute care, which is the first 72 hours that someone gets when they've had a stroke, and the acute care, which is the hospital rehabilitation part of care when after they've had their hyperacute care. So we are just looking at those two elements under this piece of work. The next slide, please. So the next slide shows the map of Somerset, and it shows that actually at the moment Yeovil and Taunton both provide hyperacute and acute care. But we also know that some patients already go outside of Somerset for their stroke care. So they may go to Bath or Dorchester or Salisbury. Next slide, please. I just want to emphasise that actually both of our stroke centres or services are providing safe care, and our staff are working really, really hard to provide the best possible care they can for people who have had a stroke. However, we know that our ageing population means that the demand for stroke will increase. There is a shortage of specialist workforce, that's locally and nationally, that we need to deliver hyperacute and acute stroke care. We know we're not providing a 24/7 consultant-led service in Somerset, and we know that our hyperacute stroke units are not set up to maximise those skills and experience of our staff. We also know we don't provide treatments fast enough, and there are new specialist treatments as Bernie said, that require highly skilled staff and the latest technology. The next slide, please. So our vision in Somerset is, following a stroke, people have quick access to the best possible care and treatments to increase their chance of recovery, regardless of where they live in Somerset. And just to go through, the National Clinical Guideline for Stroke has been updated this year in April 23. And these are some of the things that they have actually are in the guideline. So the ambulance crews should be trained to recognise stroke and to pre-alert hospitals when they're bringing a stroke patient in, so that a brain scan can be performed within an hour of arrival. And that happens now, but the ambulance service alert both Yeovil and Taunton when they have a stroke patient. And as Bernie said, they go straight through into the scanner. People who are suspected of having a stroke should be admitted directly to a hyperacute unit that cares for stroke patients. That within 4.5 hours of a known onset, so that's really important that you know the onset of the stroke, the time, people will require to have thrombolysis if they're eligible within 4.5 hours. And 12% of people who have had a stroke are suitable for thrombolysis. So that assessment is made when they actually arrive at the hospital, and that's where you need your specialist staff to really make that decision, because thrombolysis treatment can be dangerous if you give it to somebody who shouldn't have it. A hyperacute stroke unit should have a 7-day service from a stroke physician, and an acute stroke unit should have a 5-day ward round by a consultant. Hyperacute stroke units and acute stroke services should have the staffing levels that match the guidance and the recommendations in the guidance. The next slide, please. So where are we now? So we've been through a process. We had a long list of 9 options. We used hurdle criteria to shortlist them down to 6. We've had expert review panels and shortlisted down to 4 options. We then did another options appraisal, and we got down to the 2 options that have been out for consultation. And the consultation finished in April the 24th. So we are near to the final decision now. Next slide, please. So the proposals for Somerset. So we have 2 options. For both options, we're proposing that we have a single hyperacute unit, and that's at Taunton, and that patients will be taken to their nearest hyperacute unit. And this could be Dorchester, Bath, Salisbury or Taunton. For option A, we're proposing that we have an acute stroke unit at both Taunton and Yeovil. And for option B, we're saying we're going to have 1 acute stroke unit at Musgrove Park in Taunton. So what would these changes mean? So for hyperacute stroke, it means that people who have had a suspected stroke would be taken to their nearest hyperacute stroke unit, and that could be out of county. For most people in Somerset, their first 72 hours would take place at Musgrove Park Hospital. And as I said, those that live closer to other hyperacute units outside of Somerset would be taken there. We've had active support from particularly Dorset County Hospital, who've been reviewing the proposals, and we've been working with them as to the impact of our proposals on them. And by creating 1 hyperacute in Somerset, we would increase the number of patients who get high quality specialist care 24/7 and the national standards. Going into acute stroke care, so option A, where we've got 2 stroke units, 1 at Taunton and 1 at Yeovil. It means that acute stroke care would be provided by dedicated stroke teams on both sites. Patients would be transferred back to Yeovil District Hospital once their hyperacute phase is finished, which is closer to home, either from Taunton or from Dorchester or anywhere else. And staff expertise in stroke care would be retained in both the hospitals. This would also mean less impact on hospitals in neighbouring counties, because Somerset residents could transfer to their closest stroke unit. Under option B, 1 acute stroke unit at Musgrove. It means that all of the acute stroke would be provided by dedicated teams at Musgrove Park Hospital. Patients would receive continuity of care because they'd be having their hyperacute and acute stroke in the same place. There'd be a reduced number of handovers, and all our specialist staff would be on one site. Journey times, which I know has been a concern for a lot of people. So we're saying that those people who have suspected stroke would go to their closest hyperacute unit. And we know that these proposals may mean for some people a longer initial journey getting to hospital. And as we said, it is important that you get to hospital quickly when you have a stroke, but it's also important that you're seen by the right specialist staff quickly to get the best access to the right treatment. And although this may mean that journey times to hospital are slightly longer, we know that there will be an overall benefit to patients. And there's been some blue light ambulance travel times modelling, and 77% of Somerset population would be able to reach a hyperacute within 45 minutes and 98% within 60 minutes. And that's not just looking at Taunton. So our vision is by changing the way hyperacute stroke and acute stroke services are organised, we could make sure that everyone has access to specialist teams and treatments 24 hours a day, 7 days a week, whether the treatment is in or outside of Somerset. We would meet the national standards for stroke care. We'd be able to attract and retain specialist staff and support our staff better, make the best use of resources and save more lives and help more people live well after stroke. So the next steps from here is, now the consultation is finished and closed, all the feedback is being gathered and will be analysed by an independent research organisation. They will prepare a report for NHS Somerset Board, setting out what people have said about the proposals. The board will consider the feedback, and alongside that, we will look at a range of other information and evidence to look at any updated evidence that's come out since we've done this work, and also remodel the numbers. And we'll continue to share information and updates about the programme of work, and we'll publish the consultation findings report. And the final decision-making meeting will be held in public to allow those interested to hear the discussion and how the decision is made. Thank you.
Thank you very much for that. Could I just clarify, did you say the consultation was over in April 24?
24th of April,
Not
yes.
July this year, April next year?
Yeah.
Okay.
The 24th of April 23.
23?
Yeah.
Sorry.
Yeah.
It's closed now.
It's closed now. Sorry, I couldn't quite, I must have missed what you were saying. Thank you for that. Thank you. Right. Thank you very much for that. That's been very, very helpful. Okay, do we have any speakers that wish to, councillor?
Committee members.
He's not a committee member. Sorry, apologies. Just one moment, just to see if there's committee members. Councillor Bruce, I will come back to you, sir. Sorry.
Thank you. Just a couple of questions really to clarify. I'm not trying to be difficult here. The main reason that we are at this point is because there is a shortage of specialised skilled staff to be able to keep both of these two hyperacute units, both at Yeovil and Taunton. Do I understand right?
Yeah, yes, we do know that actually the Yeovil service has been is not sustainable going forward.
It's not sorry if I interrupt. It's not sustainable because there is a shortage of specialised staff.
That's right. Yeah, yeah.
I'm assuming that before we've got to this point, somebody's gone down the route of going, can we solve that problem first?
Yes.
Has that, because I've come into this a little bit late. Where can I find more information about that process that went through before we got to this stage?
Okay, I can ask Mary if she will perhaps answer that question.
Yeah, of course. Yes, so as I said, I'm the medical director of both of the acute hospitals in Somerset, and I've been a clinician working at Yeovil Hospital for getting on for 20 years now. And probably for the last 4 or 5 in a senior leadership position. And I can confirm that throughout that period of time, we've had extensive attempts to try and recruit workforce into our stroke team. We've been out to advert for stroke consultants. We've looked at reconfiguring the workforce to see if we could both make working at Yeovil Hospital more appealing, but also looking at how we could perhaps do the work differently by looking at other parts of the MDT. So are there other sorts of professionals that could undertake some of the very important tasks within the stroke team? We have offered incentives. We have liaised as a regional network with our partner hospitals and with NHSC's support to look at whether we can look for mutual aid, other methods of recruiting, shared posts. We've been very lucky to be supported by Musgrove Park Hospital to cover some of the gaps within our stroke workforce. And I think Julie Jones said a little while ago, and I absolutely would reiterate, that despite the failings of being able to recruit into those posts, despite everybody's best efforts, we have and continue to have a very safe service, but it's very much relying on goodwill, relentless hard work by a very few. And we recognise that that isn't sustainable at this point because we haven't managed to recruit, and the people who are holding up this service at Yeovil Hospital are well past retirement age. Despite the fact that Dr. Rashid is an absolute exemplar, if I'm honest, and it's testament to him that we have developed and have managed to sustain such a fantastic service at Yeovil, and he's nationally recognised for that. One man cannot be a service sustainably in the future. We also have an excellent nurse consultant, but again, two individuals do not make a sustainable service. And I don't think there's anybody within the workforce at Yeovil District Hospital that doesn't recognise that a move to a single hyperacute stroke unit in Taunton is ultimately the right thing to do for our patients, because at the end of the day, it's not about money. It genuinely is about a sustainable, high quality, safe and service that gives us the best outcomes, and that is what we want. So yes, we've looked really hard. We can evidence the efforts we've made to recruit and the evidence we've made to look at other options, but we simply have not ever managed to make that happen on a sustainable basis. We've been lucky and we've recruited, but we're a very, very small hospital with a very small team. And when you're a stroke consultant looking for a job and the country is your oyster, it is certainly a seller's market, not a buyer's market at the moment. What you're looking for is you're looking to work in a specialised centre where you can work to the top of your skill set in a larger team. You're not looking to join a team where it's going to be extremely hard work just to keep your head above water.
Thank you very much, Dr. Kane. Thank you. It's very, very helpful. Thank you. Can I go to, sorry.
Yeah, might I come back a moment on that?
Well, I beg your pardon. I couldn't see you. Sorry, Louis, you're a bit obscure where I'm sat.
Thank you. So just to clarify, so it's not about money, but actually if you at Yeovil were given the funding to have that better team and the equipment and the technology and everything, that would potentially attract the people that you need to run the unit there.
I would be surprised if we could get ourselves into a situation where we became large enough to be sustainable to make those changes. So I can't say no because you don't know until you try, but my guess is we are subscale to be able to do that meaningfully.
Thank you.
Thank you. Can I go to Councillor Osborne, please?
Thank you, Chairman. There's several things I could point on this, but just to pick up on the sustainability, South Somerset's local plan proposes 16,500 houses, which in theory should have been commissioned by 2028. Most of that development was going to come around Yeovil, which was the point I believe Eva was trying to make, that we have significant developments planned for Yeovil, Thorn Lane, Stowford, Mudford, they're all there. And there's also significant development going to happen in Dorset. So in the future, you are going to see the number of patients increase. So I will question that, looking at that longer term. Also, how much has the fact that Yeovil quietly merged with Musgrove has influenced thinking in terms of this? And also, it's a very small world, I suspect, the medical world, as small as others, where everybody roughly knows everybody else and various whispers go around. And how much more difficult has it made it if people think that a unit is going to shut? You're not going to uproot yourself if you're going to be shut, if you know it's going to close within 2 or 3 years. And you may get moved to Musgrove, you may not. So how much has that influenced it? I've got other questions as well, Chair.
Dr.
And
Kane,
that relates to ambulance.
does Dr. Kane want to answer that, or
Yeah,
somebody?
I probably can't talk to the housing expansion in the local area because I don't know enough about that to do so. But in terms of the questions pertaining to the influence of the merger, sorry, I cannot remember the councillor's name, but it's essentially that, you know, would somebody be put off because the writing is potentially on the wall? All I can say to that is we've been having these conversations for many years, you know, years before the merger was even in its infancy, and we simply have not been able to overcome the challenges that being an extremely small district general hospital with our geography and a number of other confounding factors has on our ability to attract and retain that workforce. And I genuinely, hand on heart, as a Yeovil clinician through and through, do not feel that the merger has done anything to compound the situation. If anything, the merger has actually provided us with an opportunity to improve the situation, which I think is what we're doing. So I genuinely believe that. I'm not just saying it. It is my absolute belief that this is the right thing to do for those reasons.
Thank you. Councillor Osborne, do you still want to come back? I do need to move on to somebody else because a lot of hands up now.
Yeah, I can well imagine so. I was going to raise the issue of ambulance times, but here you're talking purely on slide, oh God, if I can find it. On the journey time slide, you were talking about 77% within 45 minutes. I'd be curious to know how many were actually within 30 minutes of either units. And also that is purely talking about travelling time. What it's not talking about is the time from making that first 999 call to actually getting an ambulance to the patient, and the time taken to then get the patient in the ambulance, and then you get off to Musgrove or wherever, and then you have to then wait to unload. Those times haven't been factored in. What's the total bottom line time taken from, say, myself ringing 999 to report that somebody has had a stroke to actually them getting in hospital and being treated? That's the bottom line, is how long it's going to take.
Chair, shall I try and help with that?
If you would, please,
yeah.
thank you.
So I think it's really understandable that there is some attention given to the transit times from where the incident has happened to arrival in hospital. I think the pathway though is far more complex than that. So the relationship between the ambulance service and the stroke team is really critical. So assessment and advice is happening continuously from the moment the patient is assessed by the ambulance service in communication directly with the stroke team at the hospital. What we mean by pre-alert is that the initiation of that communication allows for the patient, because they're on this very particular pathway, not to find themselves queuing up outside of the hospital, but actually to be received directly by the stroke team, who they're already communicating with, in order to continue that handover and to get the pathway further, you know, further along. And the bit that can make that we need also to pay attention to is not just that out of hospital bit, but it's actually what happens in the hospital itself. So there is evidence that by having a concentrated effort of the expertise and the pathways and the processes within a hospital that does this as part of what they, their mainstream piece of work, actually improves the performance of the overall pathway. Similar questions arose when this form of change happened in other parts of the country. Most notably, there was in Northumbria, they needed to reorganise their stroke services for very similar drivers to what we're talking about here. And they were similarly concerned about the travel times. And what was really clear, often with these sorts of questions, it's very hard to find the actual evidence of what actually happens. So they actually studied this, and they found that they were actually able to decrease the time to scanning by about 15 minutes within the totality of the pathway, and the time to treatment by about half an hour. So it's really important that we don't just focus on the transit time to hospital, that we look at it from its complete end, as a complete end-to-end process.
Thank you. Can I move on now? Can I bring in Councillor Bailey, please?
Thank you, Chair. It's John Bailey, Councillor for Martock. Just one additional question to Dr. Kane. It seemed to me that you were implying that, than the two I want to ask, that you were implying that one of the options with the oval involved is not really a starter. Can you clarify that for me, please?
I was going to ask you to clarify what you meant. Which option is not a starter?
The one that includes the oval as an acute. There's one option that doesn't include the oval and one option that does.
No, I don't think that's the case at all. I think that everything adds up to the hyper acute stroke unit needing to be centralised in Taunton. I think it would be very difficult to argue a position where that didn't make sense for patient benefit. I think it may be that there is a case for there being an acute stroke unit on both sites. I think as much as anything, we would need to look at the outcome of the consultation. I think that's really important. It's not a time critical situation. It will require resources, but it is potentially something that could be done with looking at a single team on 2 sites and other workforce solutions. So I wouldn't say that, but I think it would be really important to see what the outcome of the consultation was to guide that. So I wouldn't say it's a non-starter. I think it is potentially doable, but I need to see all that information. It would make a lot of difference to see what people think predicated on there being one hyperacute stroke unit. And the reason for that is that everybody would say that they wanted to be closer to home if the starting point was home, but the starting point may not be. And so there are pros and cons to having an acute stroke unit on both sites. And I think Julie Jones set them out really nicely. So, the pro to having an acute stroke unit in Yeovil is that your course after the first 72 hours is nearer home, and that's probably better for families, etc. However, it does require another transfer of care, getting to know a new set of staff, more handovers, etc. And another way of looking at setting up the service so that you retain a degree of expertise on both sites. So there are pros and cons, but it's not a no. By any stretch of the imagination, it's not a no.
Thank you. So the option is still open. Can I just move on to my questions that I had to start with, please? Which is that it's all very new to me, this, so I'm going to focus on the sort of the big picture, if you like. And I think, thank you for the presentation, by the way, which has opened my eyes. But particularly, I think people have been focused on timings in this area for so long with all the publicity that it's not surprising that we're actually focusing on it here and now, really. And the one main question I'd just like to ask is that you seem to be talking about workforce planning mostly, and obviously there's some degree of facilities as well required. But have you actually talked to the other hospitals that are involved? Because that seems to be part of the strategy in terms of timings and support And it may be all very well, whatever we do at Musgrove and Yeovil, but if there isn't support from Bath, or it hasn't been agreed that that support is there, or from Salisbury or Dorset or whatever hospitals. So it's not just about the two hospitals, it's about a larger picture if you're going to deliver what you hope to. Thank you.
Yeah, thank you for that. And as I said, it's really important that actually we make sure that our neighbouring systems are able to support the proposals we're making. Dorset particularly have been part of the work we've been doing right from the very beginning and have supported us right the way through. They are in the process of enhancing their service there to a 7-day service. They've had a business case which has been successful, and so we've been working with them very closely. As far as Bath and Salisbury are concerned, we have spoken to them, we've had conversations with them, and we have letters of support from them to say that they are happy and can support us with our proposals in Somerset. So yes, we've been working really closely, particularly with Dorset on this. And as I said, we've got letter support to help us. Obviously, Bristol have just made changes as well to their stroke service. And there is the added extra patients coming from Weston who would normally have gone to Weston during the week that will come to Taunton. But there's been conversations with Bristol and Weston about that. So it's been really important. And of course, what we can't do is implement anything if Dorset are not ready, you know, with their service. So we've got to work very closely with them if we get to the point of implementation to make sure that we're not implementing something that they cannot cope with. So, yeah.
So just to clarify my understanding then, very close work with Dorset, but not so close with Salisbury, Bath and Bristol at this stage.
So Bristol have done their own reorganisation. There's not a huge impact on Bristol. Bath, Dr. Whiten and myself have had conversations with the team there, and also the consultant there is part of the clinical senate who actually looked at our proposals. So she's very aware, and I think it's the impact on Bath will be 1 patient a week. And they feel that they can sustain that with what they've got. Salisbury, we have spoken to, and as I said, they sent a letter of support to say that they're happy and that they think they can sustain any changes that we make.
Can I just add to that, if I may? So, for absolute clarity, the way in which stroke services are organised currently in England is that the different providers are organised into operational delivery networks. So as well as the conversations that we have as professionals, which is routine and right, there's actually the structure there as well that makes sure that people are paying attention to all the unintended possible consequences of something you do over here having an impact over there, so that people do genuinely have their arms around the whole thing.
Thank you. Can I move on now to Councillor Stanton, please?
Thank you, Chair. Most of my question has just been answered by Julie. Just to double check, so Salisbury will offer exactly the same hyperacute service as Musgrove will. The question is just when it gets to 7 days a week. Is that right?
It's Dorset that will offer the same.
Sorry, Dorset.
Yeah. Yes.
Yeah.
Yeah.
Okay. Chair, am I? I've followed this whole consultation for 3 months and watched a lot of doctors present about it and listened carefully today. I want to propose that this committee should be supporting the recommendations. Am I permitted to do that? In other words, I want to make a statement which says that I'm mystified as to why people are so doubtful that people whose jobs, these doctors and experts whose jobs are about saving lives, they've thought long and hard for years and now months about the best solution to the problem of there not being adequate medical specialism available in Yeovil and Hospital, and very unlikely to be. So I'm mystified as to why people are so doubtful of the conclusions that well-informed medics whose job is to save lives and save people from strokes, why people don't want to follow their advice. I mean, I'm of an age where I'm much more likely to get a stroke than I was 10 or 20 years ago. I had a stroke scare 10 years ago and was taken into the hospital in Reading. Actually, I hadn't had a stroke as it happened, but I know what it feels like to be in that fear state that something dreadful is happening to you. I've also curiously had a heart attack scare living in the Yeovil constituency and experienced an ambulance arriving within 20 minutes and getting me into Yeovil District Hospital. I hadn't had a heart attack either, as it turned out. So, having listened to the whole consultation, okay, there's a history. If we'd spent more money on training medics, and if Yeovil Hospital were bigger, maybe we could continue to have the right degree of medical specialism for stroke care in Yeovil, but we can't. So it seems to me that a conclusion has been arrived at, which is well informed, well substantiated, and we should accept it.
Councillor Stanton, what I'll do is I'll come back to you. This is why we're having this discussion. This is why we're not decision making. We are scrutinising a decision. Decisions that are on the table. So that's what we're here for. I'll come back to you. Can I, Councillor Sully, please? And can we have one meeting, please? Because there's a lot of discussion on this side. So thank you.
Thank you. And yeah, I do think we should be scrutinising the decision and not shutting it down. I am represent Mendip South community, so you've got Glastonbury and Shepton and all those rural communities around there, and I want to speak up for them as I should, which is my role. None of the options are good in terms of distance. Yeovil was, you're doubling it when you go to Taunton, but when you factor in other pressures, so people in my communities probably across the country are nervous about NHS provision for lots of reasons. And we've already discussed earlier. And I just feel that the answer to Councillor Stanton's kind of question really of why we are scrutinising this, thinking about this, debating this is, can I be told straight that I can pass on to my communities that this decision will not harm them, that there will not be increased risks to them. We won't be as the years roll by, see data that change. When you factor in all the other pressures that the NHS is under, and as I say, I feel it's a bit vague about the relationships with some of the other hospitals, but that makes no difference to my location anyway. It's still all quite a distance, and they feel fear and they're nervous. So that's why we're having to discuss this, and that's why we've got quite a lot of public participation here. Fear, nervousness about decisions like this, which do seem about sustainability, which is about savings. And we know the NHS has had a funding gap for a number of years since austerity, and that gap is probably around 40 billion.
Thank you.
So can you reassure me there won't be harm to communities, particularly communities that are rural and far away from all options?
The purpose of what we're involved in here is all about looking at how we do the best job possible to prevent harm. That's the basis of what this is about. And of course, there's huge complexity to that, which is why this whole process has been multi-layered and as complex as it has been. In my experience of working for 35 years or so in the NHS, is that we never take enough account of the harm that we cause through inaction or not taking the right decisions to involve ourselves with things that might be difficult. I think this is a really good example of where we've described a current state that is providing what it needs to do, but it's increasingly vulnerable to not being able to do that. And for us to not be taking the steps that we're taking to have a really honest and open conversation about what that means, and therefore what are the things that we need to do to try to make sure that we sustain things, that we pay attention to, as you say, where harm might be caused. I think that of itself introduces a different form of harm. I think that there's significant risk that if we don't make some changes to the way in which the services are configured, that there will come a point in the future where we aren't giving the people of Somerset access to the kind of service that they need to prevent them from actually the kind of risk of harm that I think would be possible if we didn't if we didn't take those actions.
Can I go to Councillor Hobhouse, please?
Thank you very much, Madam Chairman. Believe it or not, my main community is Castle Carey, and we are exactly 30 miles from every single option you brought up today. So Bristol, Bath, Salisbury, Taunton are all 30 miles away. So my community is at the most risk from what you're talking about happening. I am, on the other hand, going to second my friend Mike Stanton's proposal, because at the end of the day, if you tell us you cannot man the hospital properly, I don't particularly want to be 16 miles from that hospital and then find that they've got to be transferred from there to Taunton to be able to be looked after. And that has happened in the past to people in my constituents. Thank you.
Thank you very much, Councillor. Can I go to Councillor Bruce, please?
Thank you, Chair. I've got two questions. One is a question for Mark, and the other one is more about the governance and our process. Chair, sorry, this is directed at you. My second question is more about the process that we're going through as a scrutiny committee. Do you want me to hold that second question back until after the debate? I've got one question for Mark first, but do you want me to hold the second one back?
Hold the second one back.
Okay, that's fine. Sorry, Mark, you mentioned quite interested in the case study from Northumberland of somewhere where this has already been done and they've done extensive studies. You talked about studies about travel time. I think one of the important points is the continuity of care that was in the two options that we're still looking at here, to decide whether we should still have an acute stroke unit in both locations. I know from experience that it can really affect the recovery of a patient to have families close by that are visiting daily to help them with their speech, and there's lots of things that families can help to do that perhaps on the ward there isn't time to do. And I wonder whether a case study such as Northumberland actually looked into that, or do you have any other case studies that have looked at that aspect of it?
It's a really good question. The work that was done in Northumberland, as I understand it, was mainly looking at the efficiency of the pathway. I think the things that you're talking about in terms of what that quality of experience is for not just the patient but for their carers and family, I don't believe was examined in that way. The reason why we've got the two options is because I think it is very difficult actually to take a decision against which would be the best model of care. So there's genuine, what I would term of equipoise about where the balance fits in terms of what that might look like. So I'm not aware of any specific evidence regarding stroke care, but there's quite a lot of evidence about, on the one hand, continuity with teams, what it means to be, part of your community, back involved with your family and so on, and the problem is in this kind of scenario that there's a bit of a tension between those two things. So it will be, I think, a closely balanced decision.
Okay. I have to admit that's the bit I'm struggling with the most at the moment. Is the decision between those two. I think I tend to agree slightly in the fact that we are where we are. I'm not sure there's much we can do about that. We need to get the best outcome for patients, but between those two options, I'm really undecided as to which is the best way to go. But thank you.
Okay, can I now, Councillor Ashton has been very, very patient, and I've got Councillor Dart online, so I'm very conscious, but I really want to go to Councillor Ashton, who was here in the middle of the night, has been sat here with me, so not really, but he's been here a long time, so I'm over to you.
Thank you, Chair. I have a couple of issues here. First of all, I think there's a fundamental modelling fault in your timings, because I phone up the ambulance, I put a 999 call in, I've got my wife sitting there on the floor, nearly still. And because I'm a category 2 call, currently that's a 3-hour wait. The mean time for a pickup, response time on a category 2 call in Somerset is 2 hours, 49 minutes, 3 hours wait. So that's even before they come there. So what I do is I bundle her into the car and I take her down to Yeovil. Now, that doesn't give us the advantages you're talking about of being able to call in to get a fast path through A&E. I just turn up there. So that's happened many, many, many times along. I've talking to Rashid, happens. It's a very, very common occurrence. Now you're quoting 45 minutes under blue lights. Unfortunately, I don't have blue lights on my car, so it's not going to happen. Now, the other thing, I had to look at the recent Sentinel reports, and in fact, their key indicator number 6 said that Musgrave was failing on pass-through calls from ambulances, whereas Yeovil was succeeding. In fact, the key indicators were better for Yeovil than they were for Musgrave. So that's my main concern, is that you're going on the premise that everyone's going to be picked up by an ambulance that's just not going to turn up. Because I'm not going to sit there and wait for 3 hours while my wife is quietly dying I'll bundle her in the car and drive on. And probably at the moment take her off to Yeovil, because I don't know that you've quietly closed the stroke unit in the hyperacute unit in Yeovil. The second thing I have is that all the way through here, you've said the staffing levels are subpar in both centres. Now, when I was a governor of YDH, one of the issues were transferring staff between YDH and Musgrove, that people rather like staying in Yeovil. So if you close down a stroke unit in Yeovil, you're just going to end up with 45% more patients turning up in Musgrove without the extra staff being there, being transferred over. That's the first thing. And finally, there's no consideration of stroke specialist ambulances here. These have been applied all over the world in situations where you have latency problems, but no consideration seems to be put forward by the ICB towards specialist stroke ambulances at all. And I wonder why that is the case. Thank you.
Thank you.
Thank you for the question. There's a lot there to unpack, I think. What I'm going to do is deal with the ambulance questions first. And I'm wondering if Mary might be able to comment on some of the differentials between YDH and Musgrave Park Hospital. So the ambulance response times are not anywhere near where they need to be or what they should be. And that can't continue. I'm not sure that we should be designing services for the future that give in to the possibility of that being how things continue to be. And through this process, we've been in close consultation and involvement with the ambulance service, and the conversations that we're having within the NHS are all about improving that backdrop against which this sort of change needs to sit. In terms of utilising different models of ambulance care, you're right, there are some examples of where people have taken that approach, but it's not actually been taken in isolation from looking at that total pathway look. So one of the best examples actually where they've been doing some work in Dublin, actually looking at onboard scanning of patients in the backs of ambulances. But that is already happening within what is a well-organised, well understood end-to-end pathway within that part of the world. I'm not sure that doing one negates the need to actually look at things completely in the round, isn't it? It's an interesting question, and in time, undoubtedly, I think would be something that could help with the overall performance of the pathway, but I don't think it would be something that would allow us to not look, as we are doing, really carefully about what a sustained in-hospital service looks like, based on all the things that we've discussed, particularly around what it takes to have a consistently available, well-staffed, appropriately expert team of professionals available 24/7. I don't see it as being an either-or question, but I think it's a good question and something that I think we will see and hear more about over time as these opportunities develop. And then I don't know, Mary, if there's anything you want to say about the current differential in
Yeah, I can talk a little bit about it. So I think, notwithstanding the comments I've already made about my genuine belief that if we threw money, or in fact we've tried, but if we had money and we threw money at trying to increase the stroke workforce at Yeovil District Hospital, I genuinely don't believe we were going to be able to solve the problem. Musgrave Park Hospital does have a larger stroke team, and as such has had better success in recruitment. But the council is correct in saying that neither site are without their workforce challenges. What I would say is that extends beyond stroke care. I think everybody's probably aware that the NHS as a national organisation has never been particularly stellar when it comes to workforce planning, which is why we are where we are with a lack of specialists in a number of areas. And the piece of work that we're talking about today around stroke, so acute stroke and hyperacute stroke, is not a piece of work that's being done in isolation. Post-pandemic, and in fact pre-pandemic, but particularly post-pandemic and through the pandemic, you will be aware that the operational demands on the hospitals as a whole have been enormous. And in fact, it dovetails a little bit onto some of the conversations that belied the items that Mel Locke was talking to before this one, around the fact that there is a relationship between hospital care and social care that needs to be resolved. But at the moment, we have enormous numbers of patients in our hospital beds, both because of increased demand and also because of an inability to safely discharge them. Means some of the specialists that we do have, and that includes the stroke consultants, are not able to dedicate their skills purely to their area of expertise, but are having to undertake a number of other tasks. So the workforce is carrying a huge burden generally. So as well as this piece of stroke work, we're looking much more in detail about our workforce planning. So being in charge of the things that we can influence, and looking to see whether we can configure services in different ways, configure workforce within services in different ways, whether people can work in different ways and do different roles within the jobs that they do, to make sure that where there is expertise required, people are able to work to the top of their skill set. And I think the ability to better recruit at Musgrave Park Hospital, coupled with the work that we and partner agencies are doing to try and tackle the more general operational workforce conundrums that we are currently faced with, does put us in a much better position to be able to look to the future and envisage good sustainable stroke services. But it's not just about this piece of work, and I think it's really important that you realise this is a piece of a jigsaw.
Thank you very much. I'd like to go now to Councillor Dance online, please. Welcome, Councillor Dance. Thank you for your patience.
Thank you very much, and welcome as the chair. You're doing a fantastic job. Just firstly, I'd like to echo some of the comments made about ambulances. The other day in Yeovil, there was a resident who needed an ambulance, and there was no ambulances available locally, so one came from Frome. And in the end, they ended up driving, as Councillor Ashton said, driving the patient to the hospital. So it is a concern, the ambulances. But my biggest concern about the whole consultation is that actually the staff in Yeovil, and I've asked this question and I had an answer, you may be on the meeting, but the staff in Yeovil who say the unit moves directly to Musgrove have already stated that they will not be willing to go to Musgrove and work. So right from the start, we're flawed from the start, because actually we haven't got the staff who are going to be willing to go to Musgrove and work. So how are we going to cope if Yeovil was to close? How are we going to cope with the sheer number of patients which are going to be going to Musgrove? Also, Dorchester has only got one stroke consultant as well, I understand. So they're no better off than Yeovil as it stands. So how are they going to cope with a sheer more volume of patients going from this neck of the woods over to Dorchester as well? I know it's not about a funding issue, but actually the biggest issue is if we can't recruit the staff now, how is it going to be any more beneficial in Musgrove? And all we've got to do is look back 6 months ago when there was a queue of ambulances outside at Musgrove, when as at Yeovil there wasn't. They were dealing with the patients in quite a timely manner. That's my biggest concerns, is how are you going to deal with the staff not coming to not willing to go to Musgrove to work? And the other point, which a councillor made earlier on, saying that lots of the key members of the staff and the consultants are in support of this. Well, I know for a fact, speaking to consultants at Yeovil Hospital from all different departments, radiology, lots of other different departments, have all written in against the consultation. So it will be really interesting to see what comes out of the consultation, because I do know there's a number of quite qualified doctors, consultants, surgeons who are quite against this consultation, mainly because they know that you won't be able to recruit the staff at Musgrove and we'll be in a worse state than we're in now. That's my biggest concern. Thank you.
Thank you very much. Thank you. Oh, excuse me. I'm not sure that we take those points on board, though. Okay, I'd like to go now back to Councillor Bruce, who wanted to bring something up, because I think we have all talked about this in length.
Thank you, Chair. I've got some confusion about the process that we're going through here. So consultation's finished now, but the results still need to be processed by this research organisation and come back to the ICB. Is it going to make the decision? Am I right? So it feels definitely too early for us to be making any recommendations at the moment, because the process is still ongoing. I'm confused at what happened at the full council meeting. Unfortunately, some proposals were made regarding this. My hearing's not great, and in a big room with a lot of people, I didn't hear all of it. I don't think the minutes are out yet from that full council meeting. So I'm not quite sure what was proposed, but I don't really understand why a proposal was accepted at full council when we hadn't even finished the scrutiny process of this. And I don't want any rash decisions to be made. This is a massive, massive thing, and it's going to affect all of our communities, and we need to go through the right process. So I just really want some clarity in terms of what the role is of the scrutiny committee, at what point we make a recommendation, because we can, as a council, even though I believe the decision is not ours to make as a council, but we can put our opinion forward. And I think the scrutiny committee plays an important role in actually saying, this is what we think. Then the executive or full council will make the decision as to whether they go with that. But I think we need to see everything and see the whole process through before we make a decision as a committee and put that forward to wherever it needs to go to. But thank you.
If I could answer that, if I may. When the leader of the council asked, could it come to scrutiny immediately, because it was on the cards to come, because we were going to wait for the consultation to be over, I agreed, because he's the leader and that's what he wanted to do. So we brought it in, and we can bring it again. There's no reason why not, but he wanted it to be brought back to here as soon as possible. So we've got a discussion like we're having today. We can, as the scrutiny, put something forward. We're not the decision makers, but we can certainly say that we like, dislike, or whatever, and that's our role. but we don't make the final decision. So I think it's, I wouldn't say to a councillor, you cannot put a proposal forward. It is early days. The consultation, we haven't got the detail of it, and that's absolutely right. And that's what I was trying to explain to the leader. The consultation is not completed yet, but he, you know, he asked for this, and I have no choice but to accept, you know. So can I go back now to, are you happy with that, Councillor Bruce, or no?
I just want to put on record that I'm objecting really to what happened at full council, and I felt as though it was kind of overriding the scrutiny committee in a way, but I'm not fully aware of what was contained in those recommendations.
I'll put you to Jamie.
Sorry, Councillor Bruce, I just wanted to clarify what was said at council, and therefore, so I wasn't at the meeting, so I'm doing this secondhand, so bear with me. But I understand it was Councillor Purbrick who put forward the recommendations, and I think they were worded as following: Somerset Council to undertake to make representations to our partners about our concerns on the potential risks to all Somerset residents by the removal of the acute stroke provision in Yeovil. To further explore the impact and options of the proposed change, and for the Somerset Council Adults and Health Scrutiny Committee to allow for debate and public representations at the 31st of May meeting on their concerns related to risk to outcomes and Somerset Council services. And then finally, all Somerset MPs to be written to and asked to offer their support. So they were the 3 points that were put forward and agreed, I understand, at council.
Thank you. I feel quite happy that that's what we were doing. Councillor Shearer. Sorry, I'm so sorry, Lisa.
Chair, I just wanted to make the point at full council, as I was sat next to the leader, we took out the clause that indicated that this council may have any decision-making powers, and we also added all of the MPs in Somerset, not just the Taunton MP. Those were the amendments that we made to that motion brought by Councillor Purbrick, and that was agreed, and also to forward the petition to the NHS so that the strength of feeling was understood. So we were trying hard to make sure that we were only doing things that this council has a right to do, but that we were getting across to the NHS the strength of feeling in Somerset. Thank you. Thank you, Chair.
And I think that's what we've done today. I think we've done a good job today. You've been able to bring a lot of good points to this committee today. So, Jamie.
Sorry, Chair, I would just appreciate a comment from NHS colleagues on when do you feel would be the best time, if this committee felt so minded to make recommendations or proposals to that process, is this the right time for them to be doing it? Or if they leave it, are they likely to be too late in that process? Sorry to put you on the spot, but I'm mindful that our next meeting is currently scheduled. If our next meeting doesn't tie in with your consultation, with that proposal being presented in July, then this may be the only opportunity for the committee to do that.
So we won't be making a decision on this until November. Clearly, the earlier we can get your feedback in, we can make that, take that consideration. We of course take all the points that you've made today, and we'll feed that into the process that as we build up to the decision-making business case. But it would be helpful to have them sooner rather than later.
I'm going to go now to Councillor Stanton.
Thank you, Chair. My second and I were just discussing what we ought to do. I mean, I felt that we'd had a lot of consultation already because I've been to some big consultation events, and that this committee is coming to it a bit late. I don't in any way want to reduce the opportunity for this committee and members of it to scrutinise and ask questions and be clear about exactly what's being proposed. Our next meeting is 3rd of August, so that is, if we came to a view then, that's still in time before the decision is made in November. So I think on balance, I wouldn't push for us moving to a decision today, as long as we give this a final and thorough airing on the 3rd of August. But Henry may have a different view.
The Hobhouse.
I will back up Mike, but I don't agree with him, because at the end of the day, if you're going to bring it back, you're going to have another hour and a half discussion, and we're going to lose the chance to actually scrutinise other topics. And I actually would make a proposal to ask for a vote whether this committee wanted it brought back, and if the answer to that question is no, in the committee, I would then ask Mike to re-stand with his proposal, which I will again second, so that we actually have a decision after an hour and a half of discussion.
I'll come back to you in a moment. Can I go to Councillor Keach, please?
Thank you, Chair. Associate Lead Member for Public Health, and until the end of March, Leader of South Somerset District Council. So I declare that as an interest in what is happening at Yeovil. I have two questions. One, have the ambulance response times been really taken into consideration? I could give you some examples of what happened in my area a couple of weeks ago. And secondly, can I be reassured that the decision hasn't already been made?
Julia, do you want to respond?
Yeah. We have looked at ambulance response times. We still need to do some further work, and so we will include that in our as we go through the next bit of the piece of work. Sorry, I've forgotten your question.
Is the decision already been made?
No, the decision hasn't already been made, which is why we've gone out to consultation, and we need to get the feedback from everybody and really look at that and see whether there actually has been any other options that have been expressed by people, and also to just think about what's the feedback on the options that we've presented and proposed.
Okay, if we have our meeting on the 3rd of... So Dan, so you're still with us? Sorry. Well, you are with us, but I'm sorry.
Yeah, I am, but I'm on the move. Just quickly, one last question, and sorry, I may have missed it because I've been driving from events today. How many people have filled in the consultation? Have we been told that? Because when you went to fill in the consultation, the questions on the consultation were almost in a way which would make it difficult to some people to answer. And I just wondered if we could find out exactly how many people at this stage had filled in the consultation, because sometimes consultations are written in a way where you make them awkward so people don't fill them in. So it'd be interesting to know what the take up of the consultation was.
Okay, members, if anybody wishes to say, has anyone filled in the consultation here? So we've just got 2, 3. Yeah, okay. I apologise. I've got Councillor Govier did want to speak. I just don't want to miss you.
Yes, thank you, Chair. I like Henry, don't want to go through discussing this again. I do think it's an important issue, but I do think it's had a very good airing today, and I think people have had the opportunity to have their say. What I'm not clear on is what the actual proposal that Councillor Stanton was saying, because I think looking at what we're asked, what the consultation's been asked about, it's in 2 parts almost. One is the hyperacute stroke service. Should there be one, and should there be one in Somerset, and if so, that should be based at Musgrove. I don't think I've heard anyone particularly arguing against that today. And then the second part of it is around whether there's 2 acute units or one. And I thought I heard my colleagues from the NHS say that they hadn't come to a conclusion on that yet. So I think we'd be foolish to, in my opinion, to make a decision on the second part. But I think it might be helpful on the first part to say that we think there should be one hyperacute unit in Somerset, and that should be based at Musgrove. That's what I think would come out of today, and that's what I would if that's the proposal, I'm happy to support that, and then we leave the other one which hasn't been decided on, following on from the consultation, to a later date. But I don't think it should come back for a full debate. I think we should go along with what's decided, because I think as Henry said, it'll take another hour and a half, and we'll end up at the same point as we are now. Thank you, Chair.
Thank you very much. Julia, did you want to come back on any of these points before
I was only going to say that obviously it's not just the consultation document that was filled in. We did quite a lot of public events and also individual discussions, so all of that will be taken into account as well. The last I heard, we had nearly 1,000 responses, but that was just online. That doesn't include the written responses. So obviously we will need to get the numbers when the research company has finished and sent the report through.
We've gone an hour over now than what we planned, and I won't, a minute, Councillor Osborne. And the problem is, if we bring it back, we're going to do it again. What I would like to know is, when could this committee have the outcomes of the consultation?
So we're working that through at the moment. It is unlikely for the 3rd of August that we will have the detailed feedback. We'll have headline numbers, which probably won't tell you a lot more than we already know. So it will be during August that we are working as a team to understand what the consultations told us and how we can respond to that. So in terms of sequencing, I think the next meeting is then October, which feels a bit late in the process, if I'm honest, but unlikely to be there for in detail for the 3rd of August.
Yeah, I mean, the problem is for us, it's very difficult, because although we're giving opinions, it would be lovely to know some indication of the consultation process. Would be really good, you know, but if you can't do it by then we have to make a decision. So
Chair, it sounds reasonable that we might want to have an additional meeting in September.
Right. So just for this.
Well, we might fill the agenda up with other items, but I think in order to facilitate that, because I think from what Maria said, August is going to be too early for them and October is going to be too late for us. So September would seem to be a
right.
sensible.
Okay, so okay, I'll right. Councillor Osborne first, and then we'll.
Yeah, 2 points. Just to do it backwards, forward. I think we should have that extra meeting in September. I think this is too fundamental for us not to. So as we can see the consultation and we know what we're dealing with at that point. Also as well, in terms of the hyperacute unit being based at Musgrove, that's the only option on the table for a hyper unit. I think some of the concerns that people were raising at full council was that was going to be taken away from Yeovil as well. That was going away from Yeovil. I think that was some of it. It wasn't just necessarily around where acute was going to be, and that if the acute unit was moved from Yeovil, you would in effect have nothing at all in Yeovil, and that leaves a very, very large tract of rural area, because when you look at the map, all the hospitals are on the periphery of the area, they're not central, so you've got a very big, in effect, black hole there. And ambulance times cannot be ignored. I know you probably like to, but they can't. And it's worth commenting that last year there were 900 admissions for heart emergency. That is a category 1. That's why you got your ambulance in 20 minutes, Mike. If you'd had a stroke and it had been category 2, I think you'd been waiting a little longer. And one of the things that Councillor Ashton raised was the possibility that perhaps you need a mitigation here, and one of the things that hasn't been considered, hasn't been talked about, and I know there is a trust in the East that uses them, is the possibility of the specialist stroke ambulance that can be dealing with people almost instantaneously and transmitting straight back. The trust that used them apparently did a trial on them in about 2018-19. The cost was very high, about £750,000, but the trust reckoned they got the money back plus a bit more in 12 months because of the reduced time that people needed for reablement and could lead a normal life, get back to their regular lives much, much quicker, because some of that treatment could be started, or at least by the time they got to hospital, the diagnosis by the specialist staff through the scanner in the specialist ambulance, some of that work had been done before they got there. And I think it's something we shouldn't be dismissing out of hand. The fact that the money goes to the South Western Ambulance Trust for this work shouldn't come into it.
Can Julia, would you or your colleagues like to respond to that, please?
I don't think we're dismissing it. I think it's something we have discussed around other technology that we could use, which would help us get people through the pathway quicker. I think if Dr. Whiting were here, he would say we need to watch this carefully. We just need to find out the outcomes of where this is being done, because what's really important, he would say, is that scan. That scan has to be detailed enough to be able to make decisions on whether someone has thrombolysis or gets taken to Bristol to have that clot removal. And, you know, if you can guarantee that that scan in that ambulance is going to be detailed enough for specialists to make the decisions, then that's fine. But I think he would say, actually, we need to watch this, but we also need to think about other technology where the stroke team at the specialist unit can talk to the ambulance staff to think about, actually, because you can get stroke mimics, and to try and prevent those people who may have had a stroke mimic going into hospital, because then that means that actually they are dealing with those people that have had a stroke. So we're not dismissing it, we are watching and we are thinking about the ways that we could do things differently, particularly if we're going to work across in 2 sites. We will need to think about how we do that.
Thank you for that. Now, the final person I'm going to go to is Councillor Stanton.
Thank you, Chair. Just to clarify for Councillor Govia, Councillor Bruce picked up the same point. I wasn't particularly trying to get us to choose between options 1 and 2. I mean, like you, I'm not clear yet exactly which of those is better. I'd be very happy with our having an extra meeting in September. I thought Councillor Keach's contribution was extremely useful, and so was Councillor Osborne's. By the way, I was driven to the hospital, so the ambulance question didn't arise. So I think us discussing this again in the light of more information in September is the right next step.
So we will have an extra meeting in September, but it will not be a massive long discussion, because what we'll try to do is time is very difficult, and we have really, but I think having that ability to know what the consultation is saying will help us understand as well, and we can then decide on the options, and we can and we have the time to be able to put our opinion in, which is vitally important. Okay, so I'm going to move on now. So thank you very much for your input today on this. Thank you very much for coming today. And I look forward to probably seeing one of you or both of you maybe in September.
Thank you very much for your time. It's been really beneficial to us, so thank you.
Thank you. I'm going to just give you another 3 minutes now, because that was been a long, I don't normally, but I'm really nice. So I'm going to give you 3 minutes, okay? Could we take our seats, please, as quickly as possible? Can we take our seats, please? Could you take your seats, please, everyone? Please take your seats. Are we waiting for anyone? No, she's online. Are we all here? Good, lovely, lovely. Okay, now the next item on the agenda is from the Director of Public Health, which is Dr. Orla, from Dr. Orla Dunn. Yeah? You said no.
She isn't the Director of Public Health, Jen. That's what I was just kind of.
Well, you've got down there. You've written that down for me.
No, I didn't. That's the report.
Oh, I beg your pardon. Dr. Orla Dunn, I do apologise, Dr. Dunn. I do apologise. But listen, I want you to know if you've never gone to a cricket match and you've never took any interest, after this report, you really will. It is very interesting. So over to you, Dr. Dunn.
Thank you very much, Chair. Very surprising, but pleasant potential increase in job power for me. Thank you. Right, I'll just turn to the presentation. So just for clarity, this is the annual Director of Public Health report, and I'm just here today standing in for Professor Trudy Grant, who is the Director of Public Health and Population Health. I'll just bring up the screen. So, so this is the Director of Public Health report, and this year it's on the topic of cardiovascular disease in Somerset. And we've presented this, as you've introduced very kindly for us, with a cricketing theme. So the Director of Public Health report is a statutory obligation for Directors of Public Health, and it's their obligation to both produce and to choose the topic of the report. And however, as usual, we've had input from people from around the health and care system. And this year, as a little bit of a change, we'd like to acknowledge with thanks also input from colleagues from Somerset County Cricket Club and Somerset Cricket Foundation. And that's not least for the great pictures of cricket around Somerset, which we've used to illustrate the report and this presentation. So, as you can see on this slide, cardiovascular disease is a major health impact on our Somerset residents. It accounts for about 5 deaths each day from cardiovascular disease. And we know as our population as a whole is becoming an older profile, that cardiovascular disease is likely to become more prominent. And we're also seeing increases in rates of some of those risk factors for cardiovascular disease as well. So many of us are overweight, a lot of people smoke still, and people are not necessarily aware of the risk factors that they have for cardiovascular disease. So the reason that we came to this slightly curious theme of cricket for the public health report was our discussions around what does it mean to have a good innings in regard to life. And Somerset has an above average life expectancy in England. So that's good. But there's still quite a gap in life expectancy for people who are living in the most deprived parts of Somerset compared to those who live in some of the least deprived areas in Somerset. And we know from modelling that cardiovascular disease is the biggest reason for that gap. So another factor we thought about was years of life spent in good health. And this is a self-report measure, And at the moment, the healthy life expectancy in Somerset is only around 64 to 65 years. So that's not even enough to see a lot of us to retirement at the moment. And because of our long life expectancy, it actually means that Somerset residents spend an awful lot of time in poor health prior to the end of life. And we've also got inequalities in this. So we feel as we emerge from COVID, now is really the time for us to refocus on this really important public health issue. So our report covers factors which influence cardiovascular health, and we also look at some of the wider determinants on cardiovascular disease, such as where we live, our work and our social networks, and indeed also the weather. And this resonates also with equivalence of critical factors affecting playing conditions for cricketers, like the pitch, the crowd and the weather. And there's also many factors and parallels in team fitness. So the factors that make your team fit in cricket are often the things that are good for our fitness overall and keeping us healthy for longer. We've also looked at the way we want to catch cardiovascular conditions early and cricket fielding tactics. And then finally, we've looked at how COVID has stopped play and the impact on this on cardiovascular disease prevention. And then finally, we've looked at a 6 for Somerset, so recommendations that will help us address some of these challenges. And we hope that using this cricket theme will make this an engaging report and more accessible for a wider audience. So we already know in Somerset, if you like, where the most difficult playing conditions are. And this is for the 10th of our population who are living in the most deprived parts of Somerset. And on this map here, you can see the areas in blue, which corresponds to population areas who would, if we took an England approach, be living in the most deprived 20% of England. In Somerset, it's only a 10% of our area because on the whole, Somerset is less deprived than England. And we know that these are areas where challenges such as poor health, lack of affordable housing, crime, low income and opportunities for employment, and often there are also barriers to services. So we need to really check the reach of our services to people living in these areas and make sure that they're focused to ensure equity of outcome. And as I mentioned, factors around team fitness. So the most important factor really as risks of cardiovascular disease is smoking. And this graph on the right here shows the number of smokers in Somerset in the red and in England against the blue. And we can see we've gone down from just over 10 years ago where we had about 20%, just under 20% of people who smoked in Somerset. We're now down to just under 15%. But you can see that that drop in Somerset is not quite as good as the drop in the rest of England. And if anything, we look like we're faltering a little bit at the end here. So we really want to focus on smoking. There's about 60,000 smokers in Somerset, and we know that that rate of smoking, which is about 1 in 7 of all adults, is also much higher in those groups who have much greater risk for cardiovascular disease as well. We've had a look at fielding positions. So this is not something I wasn't particularly strong on cricket before this report. I probably am not now, but we were quite interested in how if you look at the fielding positions in cricket, they often back each other up. So whereas you have an extra cover position here, for example, you also have a deep extra cover and a deep cover. And there's layers of players who are covering the same part of the cricket pitch, so that if a ball goes past, you're likely to pick it up, potentially with somebody who could be stationed further back. And some of the tactics indeed are really which of these many potential positions you put your players into field. And we're aware that there's also a number of good catches for cardiovascular disease. So these are the risk factors that many of us can probably name, like high blood pressure, obesity, cholesterol levels. But possibly few of us actually know our own numbers and whether we should consider preventative actions ourselves. And one way that we can encourage people to understand their risk of cardiovascular disease is through a metric called a Q risk. So, for example, this is a Q risk analysis, looks at various risk factors for a 50-year-old white female and her risk of a heart attack or a stroke in the next 10 years would be 2%, or if you like, if there was a group of 100 people the same, 2 of those would be expected to have a heart attack or a stroke. However, if you add in some extra risk factors for this person and they actually smoke, they're also overweight and have a family history of cardiovascular disease, then their risk increases to 7 in 100. It's still fairly low, but I think what we want to do is raise people's awareness of the risk factors that they have on board and whether they want to do something to move themselves into a group of people who, on average, will have a much lower risk of cardiovascular disease. And if anyone's particularly curious about their own risk, you can go to qrisk.org and put in some details and get your own risk estimate. So our first recommendation from the report is that, like any good groundsman, we need to consider our pitch preparation. And this is probably where scrutiny committees can have the largest influence, ensuring that we design our environment so that the healthy choices are the easiest and facilitate a healthy lifestyle for people. We also want to design services which can support people in their health. And often the first thing we need to do to address a cardiovascular disease risk is to make some lifestyle changes. And we know that these can be really tough to do and that there are people who need more support. So we know that our services need to be designed and to adapt to this. But absolutely, where we can, we want to encourage people to take more ownership of their health, be more engaged, and indeed to know their own numbers. So, for example, what is your blood pressure level? How high is your cholesterol? So recommendation 3. So the Ashes is one of the iconic challenges in cricket, and in parallel, smoking is still the main challenge in public health, and particularly relevant for cardiovascular disease. So if we can help somebody to stop smoking, it's absolutely one of the most valuable public health actions we can take in terms of health benefits. So we want to drive a call to action to reduce our smoking rates to 5% or less by 2030, which is the national challenge. But at the moment in Somerset, we're not likely to get there. So our fourth recommendation is that we want to ensure that we have a really good fielding system in place to help us catch cardiovascular disease and its risk factors early. So we don't just want to be relying on our GPs, who we might see them as the keepers here, sorry, the wicket keepers. But we want to draw in other parts of our health system and also our community. So in particular, we want to have a system focused to help us find the 50,000 people in Somerset who we know have high blood pressure, but don't actually know about this. So we have a great system at the moment where you can borrow a blood pressure monitor from any library in Somerset. And I would give a plug to really encourage anyone who doesn't know their numbers in regard to this to borrow a monitor, get yourself a series of readings over a week. That provides a really good average blood pressure level to return to your GP, and then they can record this, whether it's high or low, and also advise you. And our fifth recommendation is around our treatment delivery. So again, we want to bring the wider system into this. So we know oftentimes people may be diagnosed with a condition that's a risk factor for cardiovascular disease, like say high cholesterol, but they're not necessarily receiving the treatment then, which reduces that risk. So, for example, statins are a treatment which sometimes gets a bad reputation for side effects, and people may have taken statins years ago, not gotten on with them, and then decided to stop. And we want patients to be more engaged in those treatment decisions, so that they know what available treatments there are, and to know that there's often a whole array of treatments that you can try. So if, for example, you don't get on with one statin, for example, there's other treatments that you can try, and indeed treatments that aren't statins, which can also reduce cholesterol. So we want people to really not just think it's an option of take that treatment and like it or lump it, or lump any side effects, so that they don't just give up and stop taking it. And then finally, like any good cricketer, we're very keen on planning tactics, and we want to keep an eye on the scoreboards within public health. We're starting to use our population health data to really help us understand the groups who may be missing out on healthcare or have poorer outcomes, and where we need to rethink our current practices and refine our approach to cardiovascular disease. So we want to improve that data collection. So I will pause at that point and invite any questions or comments that people would like to make.
Ola, thank you so much. This has been a really interesting presentation. As I think I may have said this to you, I showed it to my husband. He'd like to know what cow corner is. Never heard of it before.
I know this one. I believe it's a quiet part where the cows used to graze because the bulls were less likely to be hit there. So apparently that's where that name comes from.
That is so interesting. Thank you so much. I realise that's apart from the lovely report, but I also wondered whether I could ask whether this could be used in schools at all. Something like this would resonate with young people a little bit easier.
Absolutely.
I just think it's something that's interesting. They're all interesting, but this is really cleverly put together, I think, and I thank you for it very much.
Thank you.
Thank you. Does anybody have any questions, please? Councillor, sorry, Councillor, yeah, I'd already had your name down, sorry. Councillor Osborne.
Thank you. I'm interested in the graph on the slide marked team fitness. And it's the graph on the right-hand side, which shows that from 2013, where smoking was a 20% incidence, you got it as low as probably about 12%, if I'm reading that graph correctly. I'm curious to know what you did in that time to get that rate of smoking down, because since 2016 it then rose, fell a little bit, and it's now rising again, which is probably post-COVID. But what worked then, and why is it necessarily working now?
I can't give you a very straight answer to that question, I'm afraid. I suspect some of the variation in the Somerset line against the England line is due to our slightly smaller numbers, and particularly possibly changes in the recording of smoking within the GP records that this is drawn from. So we had a different system of incentives around that time in Somerset, which made a bit of difference. So that may be part of the reason that we had a bit of a dip then, and we're probably returning to a more robust estimate now. So I think that's possibly a little bit of an artifact in the data there.
Could I go to Councillor Bruce, please?
Thanks, Chair. It was just in terms of the getting people to be more active. How much do you work with? You say you're working with communities, but working with employers, because I think there's a lot of stress is a big risk factor here as well, and inactivity of being stuck behind a desk and a computer screen for too many hours without moving is a big thing. So do you work with employers as well?
We do. So one of the good preventative actions is anybody who's aged between 40 and 74 is eligible, if they haven't got pre-existing cardiovascular disease, for an NHS health check. And with our provider, we've done a lot of work going out and offering those health check sessions with employers. And on the back of some of the work that we've done through COVID and the links that we've made with some of the larger employers who have working populations who are drawn from those more deprived areas that I've talked about, we've actually been able to go in and address that focus on the more deprived population in Somerset. So yes, that's one of the examples. We have other workplace health initiatives that are going on, but that one's particularly pertinent to cardiovascular disease.
Councillor Keach, please.
Thank you, Chair. I've got one question. I've never seen a cricket match with 6 slips, but never mind. And I do know what cow corner is. I think my question is, and it's a comment that you actually made about taking this into schools. I'm all for taking things into schools, but as the vast majority of state schools in this country do not play cricket as a sport, it might be better to take it to the local cricket clubs, most of whom have a youth section.
Don't you
Yes.
think, Ola, that maybe they took it to schools, maybe they would start playing cricket? You know, there's another way around this. Sorry, over to you.
No, I absolutely. And yes, Councillor Keach, a good, very good points. I mean, this is where I think we should probably give a nod to the work of the Somerset Cricket Foundation, because they do an awful lot of good work of getting cricket out into local communities, especially where it's not necessarily a sort of a tradition and a background there. But yes, I think we'll be trying to disseminate the report very widely.
Thank you. Councillor Wood.
Thank you, Chair. We're talking a lot about smoking, but I know now there seems to be an increase, and I don't know whether this affects this by any means, vaping now. A lot of the children now, they seem to be going from, and I don't know whether that affects this as well. So maybe you can answer that.
It's a very tricky one, isn't it? Excuse me. The evidence around vaping is a lot less mature than our evidence around smoking. So we know that smoking is almost, I think it's probably the worst thing in terms of cardiovascular disease risk that's a modifiable risk factor. So it's absolutely obvious that people who smoke, if possible, should give up, and if vaping is part of that journey for them, then I would absolutely advocate that. I think we're being a little bit more cautious around vaping, because really we don't want anybody drawn into vaping as a sort of destination in and of itself. If it's an alternative to smoking, then that's a good risk modification. But I'm absolutely aware. I think as a team, we're very aware of the issues around vaping, and we're keeping an eye on that as a public health concern.
Thank you. Is anyone else wishes to? Well, as you'll see. Oh, sorry, Mr. Councillor Stand.
Just for information, I did my Q risk 3 score. I expect other people did while this was going on. Comes out at about 30%, so I'm now very worried.
Was that a 13 or a 30?
30.
Yes, high scores are not necessarily good on that one, but there's, I suppose, good take-home messages. There's lots of things that you can do to address cardiovascular disease risk. So although cardiovascular disease risk does get greater as we get older, it's absolutely not inevitable. So yes, I would certainly say there's things that can be done.
Ola, I just wanted to say something about, you said about between the ages of 40 to 74, you can get the NHS health checks. When my doctor has always done it from, you got to 60 and he calls it an MOT. And they've done it. But I noticed that many doctors don't do an MOT. And they found out that my husband had prostate cancer, which was, you know, in itself, it was such a good thing that they found that out and were able to be treated. But I notice I've got other people that don't get that MOT at all. So I just wondered, you know, whether, why is it like this? Why is it some doctors and not others? Goodbye, gentlemen. Thank you.
I think that's probably too big a question to address now. So there's different routine follow-ups that will occur for people. The NHS health check is designed for people who haven't already got a cardiovascular disease, and that is like a sort of a 5-year, really just a check to see is everything still going okay. Once you have any conditions, then you may get drawn into other follow-up services which GPs often offer, which may well be more like that yearly, as you say, some people call them birthday checks and MOTs. So yes, there's a range of different practice around. What I would say is really, it's just good. Everybody's really busy. I'm busy myself. I know it's difficult to squeeze these things in, but if you can just do these sort of intermittent checks just to see how things are going, then it can give you absolute dividends, especially if you're going to be one of the red faces in these groups as opposed to the green faces. If that's you want to pick up your risk factors and address them.
Thank you. Councillor Keach.
Thank you, Councillor Slocum. Slightly concerned at the cut-off for the free health check being 74. That means I have 6 months to get one in, because I won't be 74 anymore. Secondly, as the Associate Lead Member for Public Health, can I thank all very much for a very comprehensive, and as a staunch cricket fan, I really enjoyed it. It was one report that I read from cover to cover.
Thank you.
I'd like to thank you, Orla, because it was a very, very good, as I've said, very, very good report indeed. There are 6 recommendations. Are you all in agreement with the 6 recommendations? Sorry, I can talk, see louder. I was going to apologise for being so long, but I think today's been a very poignant day. It's been very, very, very good. And I'd like to thank you for your input, everyone, because I think I apologise about being an hour late, but I think we got there. And hopefully when we meet again for the August one, we'll have already got through we can look at the main issues from the consultation. So thank you for your attendance today, and have a lovely weekend. Bye.
Thank you, Chair.